Third time's the charm. Good afternoon. Again, my source for this is Tintinalli's Emergency Medicine, and today I will be tackling hepatic disorders. Liver disease is associated with abdominal pain, vomiting, shortness of breath, altered mental status, gastrointestinal bleeding, and even nonspecific malaise. These can all be attributed to malfunction of the liver. Hepatitis A, B, C, D, and E are major public health concerns globally. In the developed world, such as the United States, cirrhosis is the 12th leading cause of death, with hepatitis C as the leading cause of cirrhosis, followed by alcoholic liver disease. Acute or fulminant liver failure is uncommon and is caused primarily by acetaminophen or paracetamol poisoning, with hepatitis B being the most common infectious cause, a blood-borne, body fluid-borne virus. Acute hepatitis is caused by an infectious, toxic, or metabolic injury to hepatocytes. The initial injury leads to inflammation, cellular death, and eventual scarring in the liver. In chronic disease, liver parenchyma is replaced by fibrous tissue, which separates functioning hepatocytes into isolated nodules. This disruption of the normal tissue structure can become severe and lead to the central characteristics of liver failure, such as loss of metabolic and synthetic function at the cellular level, which can lead to sequelae such as coagulopathies in the form of reduced or impaired metabolism or creation of vitamin K dependent coagulation factors, which include factor 10, factor 9, factor 7, factor 2, as well as progressive development of portal hypertension, ascites formation, and portal systemic shunting at the gross level. As mentioned earlier, the liver's synthetic functions include the production of coagulation and anticoagulation factors. The liver is responsible for producing not only vitamin K-dependent clotting factors, but also protein C and S and other elements of the clotting and thrombolytic processes. Inadequate production of these clotting factors makes uncontrolled bleeding one of the life-threatening features of liver disease and a potentially dramatic complication of hepatic failure. Portal hypertension is increased hydrostatic pressure in the portal vein and its feeder vessels caused by resistance to blood flow through the cirrhotic liver. It eventually causes esophageal and gastric varices and portal systemic shunting. The increased hydrostatic pressure in the intraperitoneal veins, hypoalbuminemia, and poor renal management of sodium and water lead to ascites in the cirrhotic patients. Ascites can cause respiratory compromise and lead to spontaneous bacterial peritonitis, which occurs when normal flora translocate across an edematous bowel wall into the peritoneum. Bacteremia and infection of pre-existing acidic fluid ensue. Encephalopathy is also another characteristic of chronic liver disease and is a hallmark of liver failure. Ammonia is often presumed to be the cause of confusion and lethargy in encephalopathic patients, but the pathophysiology of encephalopathy is not completely understood in the setting of chronic liver disease. In cirrhosis, portal hypertension allows ammonia formed by colonic bacteria to enter the general circulation through portal systemic shunting. Large intestinal protein loads, such as a high protein meal or gastrointestinal bleeding, fuel this process. Although levels of ammonia do not reliably correlate with mental status, it is reasonable to think of ammonia as a contributing factor to alterations in mental status. In fulminant liver failure, cerebral edema and increased intracranial pressure may develop, and in this end-stage state, loss of autoregulation of cerebral blood flow, ammonia-related edema, and the systemic inflammatory response are all thought to contribute to this deadly complication. Jaundice may be present in any stage of liver disease due to elevated levels of bilirubin in the circulation, leading to bile pigment deposits in the skin, sclerae, and mucous membranes. These are what is responsible for the yellow pigmentation of these particular areas of the body. Hyperbilirubinemia can occur for one of three reasons: overproduction of bilirubin, inadequate cellular processing of bilirubin, or decreased excretion of bilirubin. Another way to think about this is prehepatic, hepatic, and posthepatic jaundice. Prehepatic jaundice is caused by any form of hemolysis, including inborn errors of bilirubin metabolism, which overwhelm the liver's ability to conjugate bilirubin. Viral infection and ingested toxins are typical causes of hepatic jaundice. When hepatocytes necrose, the liver's ability to conjugate bilirubin is impaired, and the level of unconjugated bilirubin rises in the blood. Unlike prehepatic and hepatic jaundice, however, which present with elevated unconjugated or indirect bilirubin, posthepatic jaundice produces a rise in conjugated bilirubin since there is no problem with the conjugation of bilirubin or its metabolism. However, it is due to obstructive causes such as a pancreatic tumor or a gallstone in the common bile duct. Parasitic infestation and biliary atresia are rare causes in the United States but are more common in other parts of the world, especially developing countries like ours. A chief complaint of jaundice, nausea, vomiting, diarrhea, right upper quadrant or epigastric pain, pruritus, inappropriate bruising or bleeding, or altered mental status should raise the question of liver disease. In the HPI, onset of symptoms after eating out or after indigestion of paracetamol in one-time overdose or chronically high doses, mushrooms or raw oysters may also be present in the HPI. The duration of symptoms would characterize acuity. Past medical history can identify comorbidities or risk factors for liver disease, such as chronic hepatitis, transfusion of blood products, positive human immunodeficiency virus status, frequent use of pain medications, or depression. Obesity, type 2 diabetes, and hyperlipidemia are risk factors specific to NASH. High-risk medications include acetaminophen or paracetamol-containing pain medications, vitamin A, isoniazid, propylthiouracil, phenytoin, and valproate, as well as a variety of herbal remedies. Statins raise concern for hepatic toxicity but are rarely implicated in significant liver injury. 3% of patients taking statins have mild transaminase elevations, but clinically significant hepatotoxicity is rare. A social history positive for injection drug use, chronic alcohol abuse, sexual promiscuity, or travel to countries with endemic parasitic liver diseases represents an increased risk for liver disease. The review of systems can identify signs and symptoms including white or acolic stools in cholestasis and brown or tea-colored urine. Stools can be black or bloody from variceal or other gastrointestinal bleeding. Patients may notice yellow skin or sclerae indicating elevated bilirubin. Ascites can increase abdominal girt or cause shortness of breath, and portal hypertension leads to generalized weakness, encephalopathic changes in mental status, and lower extremity edema. Lightheadedness or near syncope can result from intravascular depletion and abnormalities in renal sodium and water excretion. On physical examination, hallmarks of liver disease include liver enlargement and tenderness with or without jaundice, especially in acute hepatitis, but in chronic liver disease, this is accompanied by sallow or jaundiced complexion, extremity muscle atrophy, Dupuytren's contracture, palmar erythema, cutaneous spider nevi, a distended abdomen with a fluid wave, enlarged veins on the surface of the abdomen, also known as caput medusae, and asterixis. Extraordinary bruising or other signs of bleeding diathesis can be seen in liver failure. So when it comes to the breakdown of symptoms between acute, chronic hepatitis, and acute liver failure, nausea, vomiting, and diarrhea may be present or absent in all three. Fevers generally only seen in acute hepatitis but not in chronic disease, cirrhosis, or acute liver failure. Pain may or may not be present in all. Altered mental status tends to come with chronicity of the disease and liver failure. Bruising and bleeding also doesn't tend to happen acutely since it takes time for the coagulation factors to be depleted. And on physical exam, jaundice is present in all. Hepatomegaly, probably only in acute liver failure, but sometimes not, and definitely in acute hepatitis. Ascites may occur with more chronic disease. Such the same goes for edema. Skin findings such as bruising, vascular malformations also only occur with chronicity. Elevated ALT and AST may occur in all three. An AST-ALT ratio of greater than 2 may occur in all but mostly in acute hepatitis. An elevation in PT and INR mostly for chronic disease, as well as elevated ammonia, low albumin, and direct bilirubinemia. Indirect bilirubinemia may occur in all three, especially because of prehepatic and hepatic causes. Urobilinogen may be present in all three, elevated blood urea nitrogen or creatinine only in acute liver failure, and for radiologic findings, ascites is more common in chronic disease, fatty liver for acute disease, and cirrhosis for more chronic disease. That being said, acute hepatitis typically presents with nausea, vomiting, and right upper quadrant abdominal pain. A patient with acute hepatitis can also have fever, jaundice, bilirubinuria, and an enlarged tender liver. The most common causes are viral infection and toxic ingestion. Alcohol and paracetamol are the most common toxic causes. Patients with chronic hepatitis display evidence of long-standing hepatocellular damage. Cirrhotic patients with portal hypertension complain of abdominal pain and/or distension, abnormal bleeding such as bruising, bleeding gums, epistaxis or blood in the stool, and lower body edema. They may also exhibit signs of infection, encephalopathy, ascites, and electrolyte derangement. Skin examination may reveal spider nevi, caput medusae, and other manifestations of abnormal shunting of blood to surface vessels. Liver failure is the potential final common pathway for both acute and chronic liver disease. If there's a delay in seeking medical attention or a rapid acute course, fulminant liver failure can be the presenting disorder. For cirrhotic patients, the transition to liver failure is marked by the advent of coagulopathy, encephalopathy, abnormal fluid shifts, and the hepatorenal syndrome. When it comes to acute hepatitis due to viral causes, hepatitis A, B, and C are the most prevalent forms of viral hepatitis that are encountered in emergencies. Hepatitis A is transmitted by fecal-oral contamination, and although it is particularly associated with improper food handling or oyster consumption, most common transmission occurs from asymptomatic children to adults. Implementation of the hepatitis A vaccine in children has dramatically decreased overall rates of infection. It has an incubation period of 15 to 50 days, followed by a prodrome of nausea, vomiting, and malaise. About a week into the illness, patients may note dark urine due to bilirubin, and a few days later they can develop clay-colored stools and jaundice. Hepatitis A virus does not have a chronic component, and death from hepatic failure is rare. Hepatitis B virus is transmitted through body fluids such as blood transfusion, sexually, or by contaminated needles or by perinatal transmission. The incubation period is longer at 1 to 3 months, and patients can become infectious for 5 to 15 weeks after the onset of symptoms if they clear the infection. Individuals who develop chronic disease will remain infectious indefinitely. Chronic infection occurs in only 6 to 10% of patients who contract hepatitis B as adults, whereas 90% of infants and 30% of children under the age of 5 progress to chronic status, which underlines the importance of vaccination of infants and women of childbearing age. In the acute phase of hepatitis B infection, presentation is similar to that for hepatitis A, including complaints of malaise, nausea, vomiting, fever, abdominal pain, and jaundice. Hepatitis C virus transmission occurs primarily through exposure to contaminated blood or blood products. In contrast to hepatitis A and hepatitis B, hepatitis C is most often asymptomatic in the acute phase of infection, and 75% or more of patients advance to the chronic stage. The rate of progression to liver failure varies and depends on the natural course of the virus and cofactors such as alcoholism and human immunodeficiency virus infection. Along with the hepatitis B virus, hepatitis C virus is one of the most common causes of hepatocellular carcinoma. Of patients who develop chronic hepatitis C virus, 1 to 5% will die of either cirrhosis or liver cancer. Hepatitis D, as in dog, is uncommon and is typically seen in people with pre-existing chronic hepatitis B virus infection. It tends to be something that piggybacks on hepatitis B infection. Hepatitis D superinfection can result in a rapidly progressive or fulminant form of liver disease that carries a high short-term mortality rate. This variety of infection is most commonly associated with injection drug use. Acute illness with liver function tests abnormalities may occur with infection by other hepatotropic viruses such as cytomegalovirus, herpes simplex virus, Coxsackie, and Epstein-Barr viruses. These agents are unlikely to cause clinically significant hepatitis in an otherwise healthy host. Toxic injury to the liver can cause acute hepatitis and/or fulminant liver failure. The most common of these is acetaminophen overdose. It accounts for greater than 40% of liver failure cases in the United States and one-third of deaths secondary to toxic ingestion. Patients develop nausea, vomiting, and abdominal pain. They may also give a history of an acute overdose of paracetamol or chronic use of one or more paracetamol-containing pain medications. Up to 28% of patients with paracetamol overdose will develop liver failure. The likelihood of failure depends on time from ingestion to presentation, the dose ingested, and the baseline health status of the patient. In addition to paracetamol, there are a variety of prescription medications such as antibiotics and statins, herbal remedies, and dietary supplements that have been associated with liver failure and acute hepatitis. The list of prescription medications that have been implicated in liver disease is very long that it is prudent to refer to a pharmaceutical database to identify a potential culprit when toxic insult is suspected. Some of the most common herbal remedies include black cohosh, which are used for menopausal symptoms and can cause hepatic necrosis and bridging fibrosis, chaparral, which is an antioxidant and health tonic, often causes cholestasis, chronic hepatitis, cholangitis, and cirrhosis. Comfrey for broken bones, wound healing, and reduction of joint inflammation can cause hepatic veno-occlusive disease. Echinacea for respiratory infections, fever, and immune boosting can cause acute cholestatic autoimmune hepatitis. Kava is an anxiolytic and sleeping aid which can cause acute and chronic hepatitis, cholestasis, and fulminant hepatic failure. Kombucha or mushroom tea is often used as a weight loss agent and is implicated in acute liver failure, hepatitis, acute renal failure with hyperthermia, and lactic acidosis. Mawang or ephedra is used for weight loss as well and may cause acute hepatitis. Mistletoe is used for hypertension, insomnia, epilepsy, asthma, infertility, and urinary disorders and may also cause acute hepatitis. Noni juice can cause subacute hepatic failure and acute hepatitis. Prostata or saw palmetto is used for BPH and may cause cholestatic hepatitis. Senna, a laxative, may cause acute hepatitis, acute cholestatic hepatitis, acute liver failure. Skullcap, which is a sedative and anti-inflammatory, can cause hepatic veno-occlusive disease, cholestasis, and hepatitis. St. John's wort is an antidepressant that can cause cytochrome P450 induction, which is very known for, and serotonin syndrome. And valerian, which is a sedative and anxiolytic, can cause hepatitis as well. Alcoholic liver disease can range from asymptomatic reversible fatty liver to acute alcoholic hepatitis, cirrhosis, or a combination of acute and cirrhotic features. The diagnosis of alcoholic liver disease carries a 35% 5-year survival rate. If a patient has asymptomatic liver disease, such as fatty liver seen on imaging, but the patient's drinking continues and acute alcoholic hepatitis develops, the mortality can be much higher. A history of consistent heavy alcohol use, which is a mean intake at presentation of 100 grams or more, is thought to be required for the development of significant alcoholic liver disease. However, information is often difficult to elicit from the patient or family, and the patient may have stopped drinking before presentation. Other non-hepatic features of alcohol abuse, such as malnutrition, stocking glove neuropathy, pityriasis rosea, and cardiomyopathy, can be clues to alcohol-induced liver disease. Mushroom poisoning is an uncommon but important cause of acute hepatitis with a high risk of liver failure. The death cap or Amanita phalloides is the most lethal of the more than 50 types of mushrooms that are toxic to humans. Most patients live for years with hepatitis B virus, hepatitis C virus, NASH, or alcoholic hepatitis without symptoms. During the asymptomatic period, normal liver parenchyma is being gradually replaced by scar tissue and fibrosis, and hepatic disease can manifest as mild transaminase elevation or, in cases of NASH and alcoholic hepatitis, as an incidental finding of fatty liver on abdominal imaging studies. When a critical amount of liver parenchyma is replaced by fibrotic tissue, symptoms of cirrhosis develop, such as abdominal pain, ascites, SBP, general weakness resulting from electrolyte derangement, or altered mental status due to hepatic encephalopathy. Ascites is one of the hallmarks of cirrhosis and may cause a protuberant abdomen and a fluid wave on physical exam. Intra-abdominal fluid can displace the diaphragm upward and produce sympathetic pleural effusion, with a possibility of respiratory compromise. Smaller amounts of ascites can be difficult to identify in examination, and bedside ultrasound is particularly helpful in patients in which the presence of ascites is uncertain. Spontaneous bacterial peritonitis, or SBP, is a subtle yet crucial complication of ascites. The survival rate for patients with the first episode is 68.1 at 1 month and 30.8% at 6 months. This is probably a result of acute infection occurring in the fragile setting of advanced liver disease. Although common in cirrhotic patients, where 30% of ascitic patients will develop spontaneous bacterial peritonitis in a given year, it is difficult to diagnose because signs of abdominal pain and fever are not always present, and physical examination does not always demonstrate abdominal tenderness. For patients who are diagnosed with ascites for the first time or have ascites and develop fever, abdominal pain, gastrointestinal bleeding, or encephalopathy, they should undergo paracentesis to check for spontaneous bacterial peritonitis. In patients with ascites, sonographic imaging may show ascitic fluid that shows bowel loops and edematous gallbladder wall. Hepatorenal syndrome is a complication of cirrhosis that often accompanies spontaneous bacterial peritonitis. It is defined as acute renal failure in a patient with histologically normal kidneys in the presence of pre-existing chronic or acute hepatic failure. The cause is not well understood, but there are two types of hepatorenal syndrome. Type 1 is more serious and identified by progressive oliguria and doubling of serum creatinine over a 2-week period. Type 2 is represented by a gradual impairment in renal function that may or may not advance beyond moderate dysfunction. The discovery of acute renal failure, or rather abrupt renal failure, in a cirrhotic patient that cannot be attributed to any other cause should be viewed as a marker of extreme morbidity. Median survival for type 1 hepatorenal syndrome without medical treatment is 2 weeks. Hepatic encephalopathy is a poorly understood phenomenon attributed to the accumulation of nitrogenous waste products normally metabolized by the liver. It causes a spectrum of illness ranging from chronic fatigue or mild confusion to acute lethargy. The development of hepatic encephalopathy suggests either that the liver is no longer able to metabolize the usual supply of nitrogenous waste, or that the supply of such waste has increased. Sources of increased supply include protein loads from a large meal or from occult gastrointestinal bleeding. In addition to progressive liver disease, constipation, hypo or hyperglycemia, alcohol withdrawal, hyperperfusion states such as sepsis, and iatrogenic interventions may also compromise the liver's metabolic capacity. Hepatic encephalopathy is a common complication after a transjugular intrahepatic portosystemic shunt, a procedure in which portal blood is shunted to the inferior vena cava, bypassing the liver. Although this procedure may succeed in reducing portal hypertension and variceal bleeding, it also slows down metabolism of nitrogenous waste by reducing hepatic blood flow. Adding or removing antibiotics from a patient's medication regimen can also precipitate encephalopathy by changing the intestinal flora and altering the gut's ability to metabolize proteins. Determine if there are changes in personality, worsening dementia, a decrease in levels of consciousness, or declining neuromuscular function to appreciate the presence or worsening of encephalopathy. The clinical stages of encephalopathy include stage 1, which features general apathy, stage 2, which features lethargy, drowsiness, variable orientation, and asterixis, stage 3 consists of stupor with hyperreflexia and extensor plantar reflexes, and stage 4 is a coma. Asterixis, which characterizes stage 2, is elicited by having the patient hold the arms straight up and extending the wrists. The hands begin to clap repetitively. Another manifestation of asterixis is back and forth tongue movement when the tongue is extended. A patient with known encephalopathy in stage 1 or 2 who is otherwise well and has no other acute comorbidities may be managed as an outpatient after consultation with the primary care physician or gastroenterologist. Hepatic encephalopathy is a diagnosis of exclusion. In the cirrhotic patient with altered mental status or lethargy, exclude multiple other causes, even in the presence of an elevated serum ammonia level. Patients with end-stage liver disease are typically coagulopathic and may develop a spontaneous or traumatic subdural hematoma. Decreased hepatic gluconeogenesis and glycogen stores and poor nutritional status increase the risk of hypoglycemia, and nutritional encephalopathies such as Wernicke-Korsakoff syndrome may also do this. Cirrhotic patients are often treated with diuretics and can develop hyper or hyponatremia. Altered mental status can result from decreased hepatic clearance of drugs such as benzodiazepines and opiates, prolonging the effect and resulting in an accidental overdose. Renal failure and sepsis are other considerations. Always exclude upper gastrointestinal bleeding as a precipitant of hepatic encephalopathy because the protein in the blood can translocate across the bowel of the cirrhotic patient. Gastroesophageal varices and hemorrhage are also complications of cirrhosis. Liver failure is the final common pathway for several types of liver disease. Progression to liver failure is varied and depends largely on comorbid entities such as human immunodeficiency virus or acquired immunodeficiency syndrome, diabetes, obesity, continued injection drug use, and alcohol intake. Patients who develop acute liver failure have an extremely poor prognosis with survival rates of less than 30%. Among the most common of entities that present as acute liver failure include paracetamol overdose, indeterminate causes, other drugs, hepatitis B virus, and autoimmune hepatitis. The clinical hallmarks of acute liver failure are hepatic encephalopathy, hepatorenal syndrome, and coagulopathy. Again, type 1 hepatorenal syndrome is more serious and has progressive oliguria and doubling of serum creatinine over 2 weeks, and type 2 is represented by a gradual impairment in renal function that may or may not advance beyond moderate dysfunction. The electrolyte imbalances seen in chronic liver disease may become extreme. Cerebral edema and intracranial hypertension are the most ominous complications. The catabolic nature of liver failure leads to negative nitrogen balance and immunodeficiency. Other clinical findings in acute liver failure include hypotension, hypoglycemia, and relative adrenal insufficiency. Evaluation should include an assessment for sepsis. Gilbert syndrome is a familial liver disorder that produces occasional elevations in liver function tests and bilirubin. It does not cause cirrhosis or affect the synthetic or metabolic functions of the liver. Wilson's disease, hemochromatosis, and alpha-1 antitrypsin deficiency are familial disorders that can lead to severe chronic disease and liver failure. Autoimmune hepatitis is a progressive chronic disease presumably triggered by viral hepatitis or by medications. Primary biliary cirrhosis is a presumably autoimmune disorder with a chronic or chronic degenerative course. When it comes to pre and post hepatic venous thrombosis, vascular diseases of the liver are rare, but timely diagnosis and treatment can improve their outcomes. Portal vein thrombosis affects the prehepatic portal venous system and is associated with hypercoagulable states such as polycythemia vera, with deficiencies in protein C and S, antithrombin 3, and factor V laden, and with abdominal trauma, sepsis, pancreatitis, cirrhosis, or hepatocellular carcinoma. The major symptom is abdominal pain, with ascites occasionally. Splenomegaly may also occur without hepatomegaly or on physical examination. Hepatic vein thrombosis, also known as post-hepatic venous thrombosis or Budd-Chiari syndrome, has both acute and chronic presentations including abdominal pain, hepatomegaly, and ascites, which is compared with portal vein thrombosis, which generally presents with abdominal pain and sometimes ascites. Associated conditions include coagulopathies, polycythemia vera, paroxysmal nocturnal hemoglobinuria, and congenital webs of the vena cava. When it comes to laboratory tests for hepatobiliary disease, we look at markers of acute hepatocyte injury or death, measurements of hepatocyte synthetic function, indicators of hepatocyte catabolic activity, and tests to diagnose specific disease entities. Generally speaking, liver function panels include a mix of markers of hepatocyte injury, usually including aspartate aminotransferase, alanine aminotransferase, alkaline phosphatase, as well as indicators of hepatocyte catabolic activity, which are direct and indirect bilirubin. Tests that reflect hepatocyte synthetic function include prothrombin rate and albumin. Ammonia reflects catabolic function of the liver. Viral hepatitis serologies are used to differentiate various types of hepatitis. Paracetamol levels can determine whether treatment for poisoning is appropriate, and various tests of acidic fluid are used to diagnose spontaneous bacterial peritonitis. Bilirubin is a metabolite of heme proteins. Total level is usually reported along with the levels of conjugated or direct and unconjugated or indirect portions. In a functioning liver, the unconjugated bilirubin is taken up by hepatocytes, conjugated, and then secreted into bile. Bilirubin is then excreted into the stool with a small percentage being recirculated through the liver. An increased total and indirect bilirubin signifies either an overwhelming supply of unconjugated bilirubin to the hepatocytes via hemolytic anemia or an injury to the hepatocytes themselves that damages their capacity to conjugate a normal supply of bilirubin in acute or chronic viral hepatitis. Total and direct bilirubin is increased when there is some obstruction preventing the secretion of the conjugated bilirubin that is produced by normally functioning hepatocytes such as an obstructing gallstone, pancreatic mass, or biliary atresia. Transaminases such as AST and ALT are intracellular enzymes found in hepatocytes and some other cell types. Hepatocyte injury or necrosis releases these enzymes into the circulation. Elevations in the hundreds of units per liter suggest mild injury or smoldering inflammation. Levels in the thousands suggest extensive acute hepatic necrosis. Less significant elevations, less than 5 times normal, are typical of alcoholic liver disease and ASH. Marked elevations are commonly seen with acute viral hepatitis. These enzyme levels may be near normal in end-stage liver failure when the hepatocytes are beyond the stage of acute injury. An aspartate aminotransferase to alanine aminotransferase ratio of greater than 2 is common in alcoholic hepatitis because alcohol stimulates aspartate aminotransferase production. Incidental findings of transaminase elevations of 3 to 5 times normal and alkaline phosphatase of up to twice normal in diabetic or obese patients suggest the presence of NASH in diabetic or obese patients. Alanine aminotransferase is a more specific marker of hepatocyte injury than aspartate aminotransferase because AST is found not only in liver but also in the heart, smooth muscle, kidney, and brain. Elevated AST can be due to medications including paracetamol, NSAIDs, angiotensin-converting enzyme inhibitors, nicotinic acid, isoniazids, sulfonamides, erythromycin, griseofulvin, and fluconazole. Gamma-glutamyl transpeptidase production is stimulated by alcohol consumption. It is also elevated by drugs that induce hepatic microsomal enzyme activity such as phenobarbital and warfarin and may rise in acute and chronic pancreatitis, acute myocardial infarction, uremia, chronic obstructive pulmonary disease, rheumatoid arthritis, and diabetes mellitus. An elevated gamma-glutamyl transpeptidase in the setting of hepatitis suggests an alcoholic cause. Alkaline phosphatase elevation is associated with biliary obstruction and cholestasis. Mild to moderate elevations accompany virtually all hepatobiliary disease, whereas elevations greater than 4 times normal strongly suggest cholestasis. Alkaline phosphatase is a nonspecific marker also derived from bone, placenta, intestine, kidneys, and leukocytes. A level of up to double the expected value is normal in pregnancy. Lactate dehydrogenase is included in most panels for liver testing, but it is nonspecific, and moderate elevations can be seen in all hepatocellular disorders and cirrhosis, whereas purely cholestatic conditions cause minimal elevations. Hemolysis can produce elevation of lactate dehydrogenase and unconjugated bilirubin. The isoenzyme lactate dehydrogenase 5 is specific to the liver. Tests for lactate dehydrogenase 5 are sometimes useful, although not widely available. Ammonia is generated by hepatic metabolism of nitrogen-containing compounds. The hepatic metabolic failure seen in acute and chronic liver disease can therefore cause an elevated serum ammonia level. Very high ammonia levels seen in fulminant liver failure contribute to overall toxicity and signify poor prognosis. Prothrombin time prolongation in liver disease reflects the decreased synthesis of the vitamin K-dependent coagulation factors and serves as a true measure of liver function. Prolonged prothrombin time is a common complication of advancing cirrhosis, although it also occurs in acute hepatitis and exacerbations of chronic compensated liver disease. When present in acute viral hepatitis, prolonged prothrombin time often indicates severe disease with widespread hepatocellular necrosis. There is correlation between the extent of prothrombin time prolongation and clinical outcome in fulminant liver disease. Although prothrombin time is useful as a marker of hepatic function, abnormal values may occur in the presence of a normal liver. Vitamin K deficiency from a different entity such as malabsorption of fat and therefore of fat-soluble vitamins can be distinguished from liver synthetic dysfunction by administration of parenteral vitamin K. A 30% reduction in prothrombin time should occur within 24 hours in vitamin deficiency states. Albumin also reflects the liver's synthetic function. It may decrease in advancing cirrhosis or severe acute hepatitis and suggests a poor short-term prognosis. Because it has a half-life of approximately 3 weeks, albumin is less useful than prothrombin time in evaluating fulminant liver disease. Prothrombin time becomes prolonged in a matter of days. Serum albumin levels are also low in malnutrition, so low albumin levels do not necessarily correlate with the degree of hepatic disease in a chronically ill patient. Viral hepatitis serologies are often grouped into screening panels, and the diagnosis of specific viral hepatitis entities is complicated by the phase of illness, pre-existing infections, and the likelihood of a given type of infection. A patient acutely ill with hepatitis A will have positive immunoglobulin M anti-hepatitis A virus antibodies. Acute clinical illness in hepatitis B virus correlates with positive hepatitis B virus surface antigen. Positive immunoglobulin M antibodies correlate to the hepatitis B virus core antigen. So just to let that sink in again, if a patient has acute clinical illness in hepatitis B infection, positive hepatitis B surface antigen could be found, and positive immunoglobulin M antibodies correlate to the hepatitis B virus core antigen. Diagnosis of hepatitis C virus is initiated by ordering anti-hepatitis C virus antibodies. The diagnosis is sometimes masked by the 6 to 8 week delay between infection and antibody detection, as well as by the acute asymptomatic phase of the hepatitis C virus infection. Acidic fluid aspirate is tested for cell count, glucose, and protein, gram stain and culture to identify bacterial peritonitis. A WBC count of greater than 1,000 millimeter cube or a neutrophil count of greater than 250 millimeter cube diagnoses spontaneous bacterial peritonitis. Low glucose or high protein values suggest infection due to the metabolism of bacteria. Gram stains and culture results can be falsely negative 30 to 40% of the time, so empiric antibiotics should be started based on clinical suspicion. Culture sensitivity increases by using 10 milliliters of acidic fluid per blood culture bottle and by transferring the fluid to culture bottles at the patient's bedside. Cytology, albumin, lactate dehydrogenase, and tumor marker tests may also be performed in acidic patients. Non-hepatic causes of abnormal liver tests are also known, and they can occur in up to one-third of those screened, and only 1% of these patients indicate clinically significant liver disease. Hypoalbuminemia accompanies protein wasting, enteropathies, malnutrition, and nephrotic syndrome. Alkaline phosphatase elevations occur with a variety of bone diseases, pregnancy, and malignancies. Aspartate aminotransferase elevations accompany acute myocardial infarction and rhabdomyolysis. Bilirubin elevations occur in severe hemolysis, sepsis, and syndromes involving abnormal erythropoiesis. Prothrombin time elevation, although more specific for liver synthetic function, may also occur in vitamin K deficiency, chronic antibiotic use, and warfarin therapy. Urine bilirubin and urobilinogen are sometimes used as screening tests for liver disease because the sensitivity of these urine assays is 70 to 74% for identifying elevated serum bilirubin. For correlation with other liver function tests, their sensitivity is in the 43% to 53% range. Specificity for showing either bilirubin or transaminase abnormality is 77 to 87%. Blood-tinged urine will often give a false positive urobilinogen on a urine dipstick test. Taken together, these statistics do not support screening for liver disease with urine dipstick testing. Ultrasound and CT scan are both useful for initial evaluation of liver disease. Ultrasound can identify ascites and guide paracentesis, whereas formal ultrasound with a duplex Doppler is the test of choice for identifying portal vein and hepatic vein thrombosis. Both sonogram and CT scan of the abdomen can be used to identify cancerous, vascular, or infectious lesions of the liver. CT scanning of the brain is used to identify intracranial hemorrhage in patients with liver disease and altered mental status. Treatment for acute hepatitis is generally supportive. But we have to pay careful attention to associated conditions such as hyponatremia, alcohol or narcotic withdrawal, alcoholic ketoacidosis, and hypoglycemia. When treating chronic hepatitis, we take care of its many sequelae such as ascites, encephalopathy, coagulopathy, and variceal bleeding. Chronic hepatitis infection is typically treated by gastroenterologists in an outpatient setting. Liver failure requires critical care in the emergency room and consultation with the liver transplant center for disposition, including transfer if needed. Mild to moderate volume ascites can be managed with a salt-restricted diet and diuretics, both of which cause a negative sodium balance and encourage loss of acidic fluid. Recommended diuretics include spironolactone 50 to 200 milligrams a day and amiloride at 5 to 10 milligrams per day. Furosemide is often not used because it can lead to overdiuresis. To facilitate monitoring for adverse side effects, diuretics for the cirrhotic patient should be prescribed in collaboration with his or her outpatient physician. Paracentesis is the recommended therapy for large volume ascites. There are several important considerations, however, when a patient is cirrhotic. First, the patient's prothrombin time or INR is likely to be elevated. Second, the amount of fluid that can be removed without infusion of albumin to prevent intravascular collapse is controversial. Guidelines from the American Association for the Study of Liver Diseases state that paracentesis should be considered safe from a bleeding perspective unless there is evidence of fibrinolysis or overt disseminated intravascular coagulation. For therapeutic paracentesis, the same guidelines recommend the use of albumin 6 to 8 milligrams per liter of fluid removed and 4 amounts greater than 4 liters. One safe approach is to perform diagnostic paracentesis in the emergency room and defer large volume therapeutic taps to the inpatient setting or an observation unit. When it comes to diagnosis and treatment of spontaneous bacterial peritonitis, we diagnose using ascitic fluid. We obtain 50 ml for cell count, gram stain, and culture, a WBC count of greater than 1,000 per cubic millimeter, or polymorphonuclear leukocytes of greater than 250 per milliliter, or bacteria on gram stain. Empiric treatment includes cephalotaxime or other third-generation cephalosporins, or IV fluoroquinolone, which are ineffective in patients with prophylactic quinolone treatment, or oral fluoroquinolones in very mild cases with close follow-up. Spontaneous bacterial peritonitis is the most common life-threatening complication of ascites, classically presenting with fever and diffuse abdominal pain and tenderness, although these symptoms may be absent or present. In patients with known ascites, the one-year incidence of spontaneous bacterial peritonitis is 29%. Recurrence is as high as 44%, and survival in patients with the first episode of spontaneous bacterial peritonitis is low, probably a result of acute infection in the setting of advanced liver disease. Initial treatment is empiric antibiotic therapy mentioned earlier, such as cefotaxime or other third-generation cephalosporins, intravenous fluoroquinolones in patients who have not received prophylactic quinolone treatment, and an oral fluoroquinolone in a very mild case with close follow-up. Most common isolates in spontaneous bacterial peritonitis include Escherichia coli, Klebsiella pneumoniae, and Streptococcus pneumoniae. Empiric antibiotic treatment recommendations from the most recent guidelines from the American Association for the Study of Liver Diseases was discussed earlier. And although there is no conclusive evidence that proves that cefotaxime is superior to other choices, it is a widely accepted first-line parenteral treatment. To address hepatic encephalopathy, we first consider other entities that could cause altered mental status, such as infection, intracranial hemorrhage, or hyponatremia. Once it is diagnosed, treatment is aimed at reducing the production of nitrogenous wastes by reducing protein intake and suppressing the metabolic activity of intestinal bacteria. Lactulose is the current mainstay of therapy for hepatic encephalopathy. It is a synthetic disaccharide containing one molecule of galactose and one of fructose. It is minimally absorbed into the bloodstream. In the colon, it degrades primarily into lactic acid, and in the acidified environment, ammonia is trapped and excreted in the stool. Blood ammonia levels can decrease up to 50% using lactulose therapy. It also inhibits glutamine-dependent ammonia production in the gut wall. Lactose is given either orally or per rectum. The oral dose is 20 grams diluted in a glass of water, fruit juice, or carbonated drink. For rectal administration, dilute 300 milliliters of syrup with 500 milliliters of water or normal saline. The enema should be retained for 30 minutes. Coagulopathy needs to be treated if the patient has uncontrolled bleeding or is scheduled to undergo a procedure with potential bleeding complications. Vitamin K deficiency can be treated with vitamin K 10 milligrams intravenously or orally. Fresh frozen plasma can be given in doses appropriate for the patient's prothrombin level. Finally, decreased or malfunctioning platelets should be replaced with pooled donor platelets. Treatment of fulminant liver failure in the emergency room includes care of the patient's respiratory status, blood pressure, and encephalopathy, correction of electrolyte derangements, identification of cerebral edema or intracranial hemorrhage, attention to active bleeding, and careful disposition, ensuring that the patient will be assessed for liver transplant in a timely fashion. In patients with respiratory failure due to ascites, effusions, or decreased alertness, intubation may be required. Bi-level positive airway pressure is not typically an option in these cases because patients are too somnolent and at risk for aspiration. Blood pressure at this stage of liver disease is typically low due to malnutrition, bleeding, vomiting, diarrhea, and third spacing of fluid. Treat with judicious fluids, blood products, and vasopressors as needed. Altered mental status at this stage can be from encephalopathy, metabolic abnormalities, intracranial bleeding, or brain edema with increased intracranial pressure. In the case of intracranial hemorrhage, treat coagulopathy. Pain control in patients with hepatic disease. We usually avoid NSAIDs in these patients due to gastrointestinal toxicity and possible potentiation of renal dysfunction. Paracetamol in particular has been avoided in patients with any type of liver disease, but there are several trials that indicate it to be safe for short-term use at a dose of 2 grams total per day. Gabapentin and pregabalin are also safe options for neuropathic pain. Opioids are avoided whenever possible because they are metabolized by the liver and their sedative effects can be unpredictable in patients with compromised liver function. It is contraindicated in patients with a history of encephalopathy or substance use. If absolutely necessary, fentanyl and tramadol at reduced doses and increased dosing intervals are possible choices in select patients because they lack the toxic metabolites of traditional opioids. For pregnant women who can present with various hepatic or cholestatic disorders, HELP syndrome, which is hemolysis, elevated liver enzymes, low platelets, is a life-threatening process that must not be missed, because this usually occurs as part of the pre-eclampsia-eclampsia spectrum in the late third trimester or in the postpartum period. It can present with symptoms resembling viral illness, such as headache, malaise, nausea, and vomiting. Hypertension, headache, and proteinuria are other associated findings. Perinatal mortality in cases where HELP complicates a pregnancy before 29 weeks can be as high as 20%. We check liver function studies, CBC, and lactate dehydrogenase in those who present with even vague symptoms of illness in their third trimester and in any third trimester patient with relative hypertension. Definitive treatment in pregnancies later than 34 weeks is immediate delivery, whereas patients who are mildly ill with HELP at less than 34 weeks of gestation may sometimes be managed expectantly. With liver transplant patients, they could develop a wide variety of illnesses, most commonly abdominal, infectious, and metabolic. Febrile patients should be pan-cultured, and broad-spectrum antibiotics should be initiated pending further inpatient evaluation. Metabolic derangements can include hyper or hypoglycemia, sodium imbalances, and hypo or hyperkalemia. Rejection of the transplant should be a concern even in the absence of abdominal pain and tenderness. Symptoms of rejection can include nausea, vomiting, malaise, anorexia, abdominal pain, vomiting, and jaundice. Non-alcoholic fatty liver disease deserves particular mention in chronic liver disease because it affects up to 30% of the U.S. population and is thought to be the third most common reason for transplantation after hepatitis C virus infection and alcoholic liver disease. NAFLD often goes undiagnosed through the phases of steatosis, which is fatty deposits in the liver, and steatohepatitis, which is fatty deposits with inflammation, also identified with the acronym NASH, and is often categorized as idiopathic cirrhosis by the time of diagnosis and consideration for transplantation. It is associated with obesity, type 2 diabetes, and hyperlipidemia. Many patients will have fatty liver seen incidentally on abdominal imaging, and few of these patients will go on to develop cirrhosis. There is no specific treatment for NAFLD, but the mainstays of treatment are weight loss and exercise, which have been shown to reduce fat deposition and inflammation of the liver parenchyma, but not fibrosis. Schistosomiasis is a waterborne parasite that infects more than 200 million people worldwide and can cause portal hypertension by invading the portal venules. Echinococcus species can cause multiple liver cysts. Ascariasis causes hepatobiliary obstruction. Entamoeba histolytica can also cause parasitic liver abscesses. And veno-occlusive disease of the liver is a potentially fatal adverse effect of herbal remedies, chemotherapy, or bone marrow transplant. It is associated with abdominal pain, the presence of hepatomegaly, ascites, weight gain, and jaundice in a patient with concerning history. And that's it for now. Thank you.